or missteps really, that your body takes to compensate for that dwindling cardiac output. Also recall that the two main categories of heart failure we emphasized were systolic and diastolic failure. That's problems pumping or problems filling. All right, let's pick up where we left off. The prince can't make up his mind. Do I marry this kooky mer girl even though she can't talk? I mean, I do love charades, but mom and dad say I have to marry the princess of Bulgaria for politics and whatnot. What's a guy to do? Yep, star-crossed lovers. We're definitely dealing with some heart failure here. This time, we're getting our hands dirty. Instead of theoretical, we're getting clinical. Whether it's sisters, we're definitely dealing with some heart failure here. This time, we're getting our hands dirty. Instead of theoretical, we're getting clinical. Whether it's systolic failure from chronic myocardial ischemia or diastolic failure from long-standing hypertension, different symptoms will arise depending on whether it's the left ventricle being affected or the right ventricle. And that brings us to the two categories of heart failure we'll be covering in this sketch: left-sided versus right-sided heart failure. Since most of the characters will be facing us, left-sided heart failure will be represented on this side of the sketch, on the patient's left, if you will. Let's start here. See that soaked pulmonary light vest? When the left ventricle fails, the end diastolic pressure builds and the blood backs up into the pulmonary vasculature. This means an increased hydrostatic pressure in the pulmonary capillaries. Once it exceeds the capillary oncotic pressure, fluid leaks out in the lung interstitium. That's pulmonary edema, my friends. If you give it enough time, from the interstitium, fluid leaks right into the alveoli themselves. On gross lung pathology, what you'll see is a frothy pink transudate on the intraalveolar surface. Just think of the pink, frothy, yummy seafoam filling these alveoli evoking abalone. It should remind you of the classic clinical presentation of left-sided heart failure on exam. A patient with chronic progressive dyspnea coughing up that pink, frothy sputum. If you zoom in really close to those alveoli, you'll see little hemosiderin-laden alveolar macrophages, also called heart failure cells. Turns out that the increase in capillary hydrostatic pressure can cause the pulmonary capillaries to rupture. Red blood cells then leak into the alveoli and are phagocytized by alveolar macrophages. At Sketchy, those hungry macrophages are symbolized by macro cages, like these fishing cages here, rusty from disuse. All that excess iron in the macrophage binds ferritin and eventually degrades to hemosiderin. Again, this leads to the classic pinkish, rust-colored sputum produced by patients with heart failure. A patient with pulmonary edema is going to describe dyspnea or difficulty breathing, especially with exertion. They'll be all like, "Hey doc, I can only walk a few blocks before I have to stop and rest because I'm just out of breath." There are a few reasons for this. First, the swelling that occurs with all that interstitial fluid accumulation is decreasing the compliance of the lung. In other words, the waterlogged lungs feel like a tight corset. You just can't move your lungs as well. The presence of fluid also activates pulmonary C fibers, afferent nerve fibers that begin in the alveolar walls and are a part of the vagus nerve. This is represented by the big C-shaped hook and line caught on that edematous pulmonary swimmer. Several phenomena can trigger activation of pulmonary C fibers. Among them is any cause of lung hypoxia. All that fluid in there is not good for gas exchange, and the fibers tell your brain, "Hey, yeah, so there isn't enough oxygen down here, so I'm gonna keep reminding you of this by making breathing really uncomfortable. Just giving you a heads up." All right, good talk. In response, the patient breathes faster, and this is sensed as dyspnea, or uncomfortable breathing. Remember that when a patient describes dyspnea, he might describe fatigue as well, which is understandable, right? Just trying to take a breath has become a strenuous exercise. Patients with CHF will also describe what's called orthopnea. They have difficulty breathing lying flat, and the feeling is relieved by sitting up. "Hey doc, every time I lay down on the couch, I feel like I'm drowning." It's a relatively specific sign of advanced left-sided heart failure. Here's what's happening. Lying flat causes all that venous blood pooling in the legs to rush back to the heart, and that failing left ventricle just cannot handle the increased preload, which means even more fluid backs up into the pulmonary circulation. When severe, patients will awaken several times throughout the night, gasping for air. This is called paroxysmal nocturnal dyspnea. Your patient might even tell you that he sleeps propped up on several pillows at night to prevent these sensations. Seriously, ask them how many pillows they sleep on at night to get an idea of how bad the orthopnea is. Don't be shy. You might want to address the whole sleeping in storm drains thing as well. Definitely not helping. All that intraalveolar fluid buildup shows up on the pulmonary physical exam as well. So get out your stethoscope. With left-sided heart failure, fluid backs up equally into both lungs, and gravity likes to pull it down to the bases. This can be heard as bibasilar inspiratory crackles. Each snap, crackle, and pop you hear through your stethoscope is the sound of the fluid-filled alveoli popping open. It's almost like the sound of a straw slurping up that last bit of soda. And it's depicted here by a pair of bilateral snorkel tubes slurping in some air. Notice too that the water is seeping in at the bases. The presence of interstitial fluid is not isolated to the alveolar air spaces, however. Peribronchiolar edema, that is edema in the interstitium surrounding the bronchioles, can narrow the lumen of the airway. This results in expiratory wheezing, kind of like this just blatantly rude partygoer here, leaning right outside the lumen and blowing on one of those wheezy party blower thingies. This phenomenon is known as cardiac asthma, though it's completely unrelated to classic asthma, a reactive inflammatory narrowing of the airways in response to certain triggers. Just remember, not all that wheezes is asthma. That's enough. All right, the imaging study most commonly ordered in patients with suspected heart failure is a chest x-ray. The characteristic x-ray findings to watch out for will be illustrated here, up on the boardwalk, where the Mardi Gras festivities are in full swing. Take a look at that first float going by. That X Jolly Roger is our recurring symbol for x-ray. It'll pop up throughout the sketchy path course whenever we want to highlight chest x-ray findings that should clue you into a specific disease process. We'll usually try to show areas of increased density as white objects over a background of black pulmonary sails. For example, you see that tree mast sending its branches across the top of the sails? This represents the diffuse vascular congestion, sometimes called cephalization, of pulmonary vessels that occurs in patients with left-sided heart failure. Look for pulmonary vessels that are more defined than usual, emanating outward in the upper lobes. When all this increased pressure in the pulmonary circuit progresses to interstitial and alveolar edema, you'll actually be able to see the intraalveolar fluid as fluffy bilateral opacities, kind of like the fluffy infiltrative fog that's rolling in. It's classically described as a bilateral batwing shape and spreading out from the center. Fluid accumulation can also occur between two lobes of the lung. This mild separation can be seen on the x-ray film as a little kinda line thingy that sits perpendicular to the pleural surface, I guess. Anyways, it's called a curly bee line. It's represented by this curly bee sign, and you should probably just remember the term curly bee line instead of recognize it on an actual radiograph. They might mention it in a question stem on the test, but let's face it, I've seen curly bee lines on the wards like twice. And by seen, I mean nodded to the resident. Yeah, I see that. So obvious. Okay, as mentioned earlier, peribronchiolar fluid accumulation causes narrowing of the airways. This makes the interstitium that surrounds the small airways more opaque, while the airways themselves stand out a bit more because they're less dense and therefore darker in comparison. This narrow, dark line peeking in is called an air bronchogram. It's like the shadow of an airway overlying the opaque, fluid-filled interstitium, and we've represented it here behind the float's captain as he casts a shadow against the opaque, infiltrating fog. Finally, most cases of CHF are associated with cardiomegaly, which will be evident on the chest X-ray as an enlarged cardiac silhouette. In other words, a big white heart that takes up more than half of the thorax. Next up, the cardiac exam. Patients with heart failure might surprise you with a few extra heart sounds. These gallops are called S4 if it comes before the normal S1, S2, lub dub, and S3 if it comes after. Let's start with S3. It comes right after S1 and S2. Do you hear it? It's that subtle beat right after the lub dub. Think of the phrase sloshing in, sloshing in, sloshing in. The ing-in representing S2, S3 gallop. This results from blood rushing into a volume-overloaded failing ventricle. Think of it as a little sloshing noise that occurs as the ventricle starts to fill again. The blood coming in smacks up against the leftover blood that the heart couldn't eject. At Sketchy, that sloshing is embodied by a pink and deliciously frothy slushy, with S3 conveniently incorporated into the logo. S4, on the other hand, comes right before the S1, S2 lub dub. Listen for that subtle first little stutter before S1, S2. This time, think of the phrase, a stiff wall, a stiff wall, a stiff wall. A stiff is the S4, S1 gallop. This occurs during the atrial kick, when fluid shooting into the ventricle hits a stiff, poorly compliant ventricular wall. Bam! And that's why our recurring Sketchy symbol is a stiff-walled S4 chair, an uncomfortable yet fitting throne for the Mardi Gras queen. Though there is considerable overlap, an S3 is classically associated with volume-overloaded systolically dysfunctional hearts, which, as we learned earlier, are usually dilated and floppy, whereas an S4 is associated with stiff, hypertrophic, diastolically dysfunctional hearts, a result of chronic pressure overload. All right, besides gallops, keep your ears open for murmurs. Progressive dilation of the left ventricle can displace the papillary muscles outward and stretch open that fibrous ring attached to the mitral valve leaflets. This leads to mitral regurg and a systolic murmur. Remember, whenever we want to illustrate a systolic murmur specifically, we'll include that sweet, bubbly systolic spray. Just think of our recurring and perpetually drunk Jester here, getting a little too carried away with the festivities, dilating and regurging all over his bicuspid hat. All right, time to call it a night, Jester. Check out our valvular pathology video for more specifics about diagnosing mitral regurg. I want you to pay attention to that big dilated balloon he's sitting on as well. It's supposed to evoke an image of an overly distended atrium. You see, when that mitral valve is opened up and all that blood is shooting in the wrong direction, it can lead to chronic dilation of the left atrium, which can cause atrial fibrillation, an arrhythmia that involves uncoordinated, chaotic atrial contractions, felt as an irregularly irregular heartbeat. Just like the irregularly irregular signal reaching this cardiac television screen. Check out our arrhythmia video for a more in-depth discussion of AFib. Okay, if you couldn't tell already, this whole left-sided heart failure thing can really do some damage to the endothelial lining of that frail pulmonary vasculature. The response of the vascular endothelium is to produce less nitric oxide, a vasodilator, and more endothelin, a vasoconstrictor, resulting in increased vascular tone. Because nitric oxide is a gas, we usually represent it as billowing clouds of nitric oxide exhaust. But as you can tell, the engine here has become oversaturated from all that left-sided heart failure nonsense. Just take a look at that damaged vascular exhaust pipe. Not much nitric oxide left. Instead, we've got endothelins and vasoconstriction, embodied by that twisted red shirt. Whoa. Keep the shirt on, dude. You didn't get that wet. Eventually, the pulmonary vasculature undergoes remodeling, which involves collagen and elastase deposition. This causes intimal thickening and fibrosis. Intima means the innermost layer of the vessels. That badass shark tattoo, by the way, is our symbol for cartilage deposition. You know, because sharks are all cartilaginous? Cartilaginous? Cartilagey? It's cartilagey. Smooth muscle cells proliferate as well, hence his smooth muscular physique. This causes medial hypertrophy specifically, the media being the middle layer underneath the intima. Let's keep the big picture in mind here though, because all these changes lead to pulmonary hypertension. It's just like our fish friend here, pulling on that pulmonary arterial tree. So much tension. And the right ventricle has to try and pump blood against all of this tension. As the pressure builds inside that right ventricle, it also starts to fail. In fact, the most common cause of right-sided heart failure is left-sided failure and its associated pulmonary hypertension. Yep, it's time to switch the discussion over to the right side. When your right ventricle doesn't pump, fluid backs up into the systemic vasculature and pools in gravity-dependent areas. So, instead of wet lungs, you're left with wet extremities. This will be depicted by the submerged extremities of the mer people as they try to convince the mer princess to stay in the sea. I mean, come on. The human world, it's a mess. Life under the sea is better than anything they got up there. Whoa. Hey, my contract explicitly says no singing. Put the kettle drums away. All right, where were we? Yes, right-sided heart failure. Though left-sided heart failure leading to pulmonary hypertension is the most common cause of right-sided failure, it turns out that there are numerous cases of pulmonary hypertension, each one of which can lead to right ventricular strain. There's primary pulmonary arterial hypertension, for example, a disease of the pulmonary vasculature. Various chronic lung diseases can cause pulmonary hypertension. Instead of covering them here, check out our pulmonary hypertension video for more in-depth discussion. One term I wanted to throw at you though, anytime a lung pathology causes pressure buildup and right heart failure, this is called cor pulmonale. I think that's Latin for your core getting screwed over by your pulmonale, if I'm not mistaken. In this scene, it's represented by this cork here, putting a plug on the heart. Yet another message that will never make it to her beloved prince. So sad. What else can put strain on that right heart though? How about chronic pulmonary emboli, building up in the pulmonary arterial tree? Represented by these little thrombotic cucumber clots. Or better yet, how about one big acute clot? When it's ridiculously big, it's called a saddle embolus, and it immediately puts a ton of strain on that right ventricle. We'll talk about it more in our pulmonary embolus video. For now, just look at this cute little seahorse. It has a saddle, because seahorse. What more can I say? Keep in mind that pathologies affecting pulmonary flow, such as pulmonary hypertension, pulmonary emboli, and pulmonary stenosis, each act as a big load that the right ventricle has to push against in order to eject its contents. This is afterload, and that's why we brought back our recurring symbol for increased afterload. The little mermaid pushing against a load. Her stern father, that is. There are, of course, numerous other heart failure etiologies that can affect preload and contractility of the right ventricle, such as ischemia and cardiomyopathies. These were all covered in the previous video, so make sure to check it out. In fact, you really shouldn't have skipped that first sketch, unless you're trying to spoil the ending of the story, I guess. Shame on you. All right, so we've gone on and on about the physical exam findings in a patient with left-sided failure. How about right-sided? First, the cardiac exam. It's the same as last time. When that right ventricle fails, pressure builds up and stretches open that fibrous ring attached to the tricuspid valve. So instead of mitral regurg, now we've got tricuspid regurg and that characteristic systolic murmur. Remember, whenever we want to illustrate a systolic murmur specifically, we'll include that sweet, bubbly, and usually excessive systolic spray. And whenever we want to depict tricuspid specifically, just look for those three peaks. Again, that big atrial balloon should remind you of atrial dilation and risk for arrhythmia. More pressure in the right atria also means a backed up venous system. Let me show you what that looks like. The jugular veins on each side of the neck dump all the blood from your head into the superior vena cava, which sends it to the right atrium. So, because of their almost direct association with the right side of the heart, the jugular veins act like little pressure gauges, warning you about right heart failure and pressure overload. On physical exam, what you're looking for is jugular venous distension, or JVD, and at Sketchy, this is represented by big blue distended jugs. They even have R-shaped handles to remind you of right heart strain specifically. Measuring JVD involves leaning the patient back around 45 degrees and looking for those distended neck veins. Oftentimes, they're pretty difficult to spot, and if you're still unsure, try applying gentle pressure to the right upper quadrant of the abdomen. This elicits what's called hepatojugular reflux, which, in pathologic states like right-sided heart failure, will cause blood that's pooled in the liver to get squeezed out and fill the veins of the neck. It's kind of like the Little Mermaid's ex-mer boyfriend here, eliciting some major jugular overflow with that platter of the Little Mermaid's favorite food, fresh liver. Psh, not going to work, Brayden. A related exam finding is what's called Kussmaul's sign, not to be confused with the Kussmaul's breathing pattern seen in DKA, but that's for another video. Kussmaul's sign goes a little like this. When you breathe in, your lung kind of sucks in a lot of blood with it into the pulmonary vasculature. All this blood is coming from the right side of the heart, so the jugular veins empty out as well. This is normally seen as a decrease in jugular venous distension during inspiration. However, in the setting of right-sided heart failure, no matter how hard you breathe in, you just can't get that failing right ventricle to empty its contents, and blood backs up into the jugular veins. So JVD paradoxically increases during inspiration. Just look for that guy raising up the JVD jug and taking a big whiff of that Kussmaul cookie smell. Though it's most often associated with chronic constrictive pericarditis, it can also be found in severe right-sided heart failure, in addition to restrictive cardiomyopathy or tricuspid stenosis. All are times when the right heart doesn't want to fill, and we'll bring back this symbol each time. In your systemic venous system, there's going to be some major hydrostatic pressure buildup, and this pressure will go straight to your pants. And by that I mean straight to the lower extremities. This will manifest as lower extremity swelling, as fluid leaks out of the vessels and into the surrounding interstitium. So on the physical exam, check out your patient's legs. You might be able to feel edema, and even leave depressions in the skin with your fingers. That's called pitting edema. Yep, she's all packed and ready to join the humans. See that soaked pleural shirt and waterlogged pericardial briefcase though? Turns out that systemic congestion can cause serious fluid buildup in other extravascular spaces as well, like around the heart and lungs, which is seen as pleural effusion and pericardial effusion on X-ray and echocardiography. Check out the pleural and pericardial videos for more specific imaging and physical exam findings. What about the liver? If we work our way backward down the vena cava, venous congestion will eventually reach the hepatic veins, and then further still into the central venules of the liver. The venules expand with blood until they just can't take the pressure, at which point the surrounding hepatocytes in the central lobular zone undergo hemorrhagic necrosis. The central lobular zone is also called zone 3, hence the course 3 sign introducing the next meal. Passive congestion of hepatocytes causes the central lobular areas to be darker than the surrounding parenchyma, and is sometimes called nutmeg liver based on the gross appearance. And in a last-ditch effort, her mer friends have brought out the fresh nutmeg for dessert. Man, if this is what life under the sea is like, count me in. Clinically, all this hepatic congestion may result in painful hepatomegaly. That means the liver is enlarged, like this chubby sea cow here. And when your patient takes a deep breath and you press on that right upper quadrant, it's going to hurt. Poor guy. Let's keep working our way backwards, down the venous system. Eventually, we'll find the pressure building up on the other side of the liver, in the portal circulation. This is the special blood supply that delivers absorbed molecules from the GI tract to the liver. This portal hypertension is represented by this porthole window, under a lot of tension, if you can't tell. If enough portal pressure builds up, fluid leaks out into the peritoneal cavity. This is called ascites, and will be reported as abdominal fullness by your patient, depicted here by that abdominal ascites inner tube. So, what do you guys think? Will she join the humans? Will she stay behind and dine on that mouth-watering nutmeg liver? As we take in the entire sketch, remember the clinical clues that distinguish left-sided heart failure from right-sided heart failure. While both can manifest as dyspnea on exertion, S3 and S4 heart sounds, regurg murmurs and arrhythmias, pay attention instead to all those lung findings related to left-sided failure and those systemic volume overload symptoms, including JVD, that pertain to right-sided failure. All right, for our next video, instead of heart failure, we're going to shift focus to one of the most common causes of heart failure, cardiac ischemia.